Mr. Chair, members, Tim Madden representing the California chapter of the American College of Cardiology, and we are also in an opposed unless amended position, and we concur with the comments made, thanking the authors and particularly their staff for their time. They've been nothing short of outstanding. To focus on a few areas that haven't been mentioned already, to the extent that there is a lack of clarity in the payment standard that's established, so this is 125% Medicare, or more specifically around the average contracted rate, we believe more of these claims will end up in the IDRP. So this is a dispute resolution process. We believe there's some good things in the bill related to that, but there are still a few areas that need further definition. We believe there should be a payment standard put in place, similar to what's in place for emergency services, which is the use of what's called the Gould criteria. This way, we know what exactly the department or the arbiter is using to base their decision on what the right payment level is. We also believe that when it comes to the payment of the disputes, that it should be a system where the loser bears the cost of the arbitration process. The bill currently says that the fees would be shared between the two participants, and this could act as a barrier for physicians going into the IDRP. So when we look at the payment structure, we believe most of the disputes will be coming from the physician side. We don't foresee the health plans saying that 125% of Medicare was too high of a payment to physicians. Now, one provision that hasn't been talked about is if a physician is able to get an agreement with a patient at least 24 hours in advance of the procedure, then they don't have to be subject to the payment process that we've been describing, which we think is a good thing. We like to thank the authors for making that change from 72 hours down to 24. For cardiology, there are some times when our members are serving on call in hospitals, and someone will come in through the emergency department. And as you all know, the job in the emergency department is to stabilize the patient and get them to the next level of care. Now, the person might be stabilized and admitted into the hospital, but they may need further care in a short period of time, a period of time that would not allow for them to get that 24-hour in advance agreement set in place. So it's a little bit of a unique area, and we've been talking with the authors and their staff about this, but we believe there should be some provisions as it relates to on-call physicians in these unique situations. And one additional thing on the average contracted rate, going back to the payment provision, is we believe the regions that it's based off is too broad. The example that was given to me is that a cardiac surgeon could have a contract at Cedars Hospital, nice part of town, and they could have also a contract at California Hospital, which is just right off of Skid Row. To the extent that those contracts are averaged together, in their view, doesn't seem to make sense, and their suggestion would be to try and use the average contracted rate at the specific facility. That seems to be the best measure, the best reflection of the value of the service that was given at that time. We look forward to be involved in conversations moving forward, and thank you again.
Mr. Chair and members, Tim Shannon representing the California Orthopedic Association. We come at this from a slightly different perspective. First of all, we also would like to thank the author and the co-authors for all the work that's been done on this. Surprise billing is normally not something that surgeons experience, and if you've ever had surgery, you've probably met with your physician well in advance of the surgery, and you've had a consultation, and very soon in that process, you will find out, if you are the patient, whether or not your physician is in network. Do have the concern, though, and I was a little unclear from the committee analysis, whether all of the 16 amendments that are listed on page 12 and 13 are going to be in the bill. They will. That's good to hear, because we have the same concern that's been voiced about on-call specialists. It's very difficult to recruit on-call specialists, and any barrier that is put into that process will make that even worse. So it's heartening to hear that there's going to be language in the bill that will exempt on-call specialists from the provisions of this bill. Thank you.
Mr. Chair, members, Bryce Doherty on behalf of the California Society of Anesthesiologists. It's deja vu all over again. We could talk about this issue for days, but in the interest of time, 2 points. One, I'd like to add our compliments to Mr. Bonta for his dogged commitment to the issue. He's kept the band together for 18 months, which is quite an accomplishment on such a complicated issue. And number two, we strongly believe patients need to be out of the middle of these disputes. This is not a new issue, so crossing that Rubicon is a major, major accomplishment in this building. In exchange for that, we also want to make sure that the bill does not include include any perverse incentives that would not encourage a health plan or a physician to come to the table and enter into a fair and reasonable contract. And to that end, some of the amendments that we would like to highlight that we're still continuing to work on surrounds the applicability of the bill. So we too want to make sure that what sorts of on-call services, particularly post-stabilization on-call services, are subject to the bill, which ones would not be subject to the bill. Oftentimes, physician anesthesiologists do not have the pleasure of going into the operating room on a scheduled surgery, number one, and number two, we want to make sure that patients still can enjoy using a PPO product and going to any provider that they choose. So we also want to make sure that that disclosure is very clear and the patient and the providers understand the method and manner by which a patient can elect to not to be subject to that bill. For those reasons, we continue to work with the author, and looking forward to moving forward.
Thank you. Anyone else?
Good afternoon, Dave Butler, representing Bob Ackerman, who represents the pathologists and radiologists, and similarly to CMA, oppose unless amended. Thank you.
Thank you. I see no other support or opposition. Is there any questions? Yes, Senator Roth.
Thank you, Mr. Chair. I'm just curious, why not provide for prevailing party fee recovery? Maybe I missed it. If I did, I apologize for being late.
You didn't miss it, Senator. Thank you for the question. So I think you're referring to the IDRP and the issue of loser pays. So we've been trying to get to a place on the IDRP that is a place of common ground and a place where we can get a bill signed. There's a broad agreement on binding and mandatory, so we have that now. But we don't have two things that have been proposed by largely the provider side, and that one is baseball arbitration and another is loser pays. We don't think we can get a bill signed that has those provisions. So, and I don't know if, would you like to add anything else? Okay.
Thank you. Thank you, Mr. Chair.
Senator Pan, question, comment?
Yes. First of all, I want to thank the numerous joint authors for your work on this bill. And I mean, I see many improvements since its predecessor bill was discussed, and I appreciate what's been going in on that. And in fact, I certainly always said I supported the goal of getting the patients out from in between. Right, a patient. Actually, when they purchase a health plan, they have supposedly the expectation is that they purchase a health plan. The health plan is supposed to take care of the network, and so they shouldn't have to worry about extra expenses unless they purposely do so. If you purchase PPO and intentionally go out of network, and so that's the promise that they get from the plan. And so I think what's important is that we have to be sure, and I do hear from the plans too, is that we need to encourage a place where the contracts will happen. I mean, the reason this happens is because we have situations where plans don't have networks, full networks that allow people to just stay in network unless they choose not to. And I think we need to be sure we address that particular issue. And I know I've talked to the proponents of this bill about the network adequacy issues that need to be addressed. So, for example, I believe in this bill, and correct me if I'm wrong, that what happens is this is triggered. What happens is that someone says, okay, I'm going to a facility, right, that has a contract. And hopefully they've met with the surgeon. That's a procedure. I mean, there's different circumstances, right? And we're moving, obviously the ER doesn't fit in this. And so what happens is they go, and so they're told the facility has a contract, and hopefully they're talking to the primary surgeon, and in the examples, and they have a contract. The issue is that, is there been adequate efforts that have been made to have contracts with the other physicians who are necessary for the care? Now, often, anesthesiologists, if you may have a biopsy, a pathologist, radiologist, and so forth. And so I think, because our current network adequacy standards don't really address that, it's kind of more oriented toward whoever is your either primary care or the main point of contact physician. In fact, I think in previous versions of the bill, I said, I suggested a slightly different approach where you had someone who's a responsible physician, but since that's not on the table at the moment, or hopefully may come back to the table, the idea is that, so what happens is that you go and, you have surgeon and so forth, but you get a bill because you didn't know that you had that the person, other people were involved taking care of you. And so one of the questions is that, what are we doing to try to be sure that, to get both of those other players onto the table? Now, some people have made some statements saying that, well, there are groups, I don't know, certain ones that don't like to contract, although, doing a little asking around, and someone can correct me if I'm wrong, but because it's not a formal survey, so, being a good scientist, public health guy, I don't want to, it's not a formal survey. But I have not been able to encounter a group of anesthesiologists who don't contract with anybody. They've all been willing to contract with people. They don't necessarily accept everything, but I don't think anyone does. If someone offers you a bad deal, you turn it down. And so I don't see the problem as being that we have, and if we have doctor groups that just absolutely are not willing to contract with anybody, that's perhaps a different situation. But I think for most part, most physician groups, who represent the anesthesiologists, do have contracts. And so I think one of the things that we don't have a situation where is that, okay, and again, I know you're trying to come up with if you don't have a contract, we'll try to come up with some fair payment rate, but that you have a situation, and that's fraught with its own perils, as we heard actually both from not only the opponents, but also from the tweeners, right? Well, that's better if we can get people to negotiate it out, that you have a situation where the person that the plan not only just contracts with the facility, but they actually made reasonable efforts to have a contract with we can call it supporting cast, although they're very important. I mean, I would call them supporting because they're absolutely necessary. You need to, God forbid, if you want surgery without an anesthesiologist, you'd be in big trouble. So I hope that you could consider some sort of standards around that, because in the end, what we hope, right, in the end is that we will need to use this mechanism as little as possible. I hope we can all agree on that, because that's the least likely opportunity for a surprise bill, right? Because you have a contract, it's all taken care of, the plan's all organized and so forth, you're not gonna get a surprise bill. The problem is what happens when you have a situation where you do have one, right? And what do we do about it so we don't have patients stuck in between? So, I hope that there be some openness to consider, and I'm certainly happy to work with all of you on that, from my perspective, to try to see where we can get some provisions to address that. So sort of what I call preventative provisions, right, to help prevent these situations. And so maybe I'll first, I'll pose that question to you. Is that something that you're open to looking at?
In short, yes. I think there's been some preliminary thinking already on this, especially given some of the concerns that have been raised. We know that this issue of network adequacy was always kind of lurking in the background. And should we get out of this committee today, we're willing to work on that over the course of the next month to see if we can come up with something.
Okay. And then I guess the next issue has to do is, I know you took an amendment around, and this came up in some of the testimony. So as you're now the out-of-network doctor, we have this provision, and so you get a payment from the plan based on the standard that's in the bill, but then you're responsible for chasing down the copay, right? So apparently, I guess originally the thing was that the plan would take care of it, plan would collect the copay, so that you don't have the doctor trying to chase around for however much the copay is, which actually, frankly, collection costs will probably swallow up most of that anyway. You're not really going to get that much back. I understand that there was, I understand the plans have some concerns. That you were asked to take that out, or at least remove that piece. I guess the other question then is there a way, because if you're going to have to collect the copay, I mean, if you ever, sorry, I'm a doctor, so if you ever have to collect the copay, it's better that you try to collect it up front than trying to chase someone down after you provide the service, right? Is there then going to be some provision to say that, well, if you're going to be out of network, I mean, that's one issue, that you're going to be taking care of out-network patient, and the opportunity to inform the patient, because back we want the patient to know what their share is, right? And the problem is that the plan has to notify, because if you're out of network, you don't know what the plan's provisions are for the patient, right? How would you know? You don't have a contract with the plan, so the plan would have to go and tell you, this is your copay, the copay that that patient needs to pay, so you can have that conversation with the patient before you provide the service and then afterwards. So maybe, do you want to try to adjust that?
Well, no, and thank you, Senator Pan. I appreciate that. As a provider myself with that history, I think, and so obviously the chair as a provider as well recognizes that as providing service to someone, having insurance pay their portion and collecting the copay. The collecting of the copay has always been the responsibility of the doctor, the provider. And obviously we were looking at another mechanism to try to maybe shift that burden a little bit, to make it, to try to compensate for some of what we were feeling was to level the playing field, so to speak, for everyone. That we found, I think, that the mechanisms for that were a lot more complicated than we expected. And so if we cannot arrive at that, I would like to arrive at something that helps to create a little bit more equity. I think one of the things you're seeing here today, this is obviously an incredibly complicated issue. And as you see, unlike with 533, where you had one group very, very opposed and one group in strong support and consumers well protected, you're now seeing concerns and opposition from everyone. And that in my mind makes me feel like we're actually getting closer to a solution, quite frankly. And at least something more balanced that we can see. And what you do not see here are consumers objecting, or consumer groups, or consumers of healthcare objecting to what we're trying to do. We are trying to level the playing field a little bit, and I hope this is a work in progress, we go forward working on this. We're happy to have those continued discussions.
Yes. So no, I really appreciate that, and again, I think the goal is to try to help keep consumers out of the middle, and frankly, what is a very complicated system that's evolved in terms of payment and so forth. So I guess the other question I also had, we talked about network accuracy, copay, is in terms of, so I know that in past discussion of 533, actually there was testimony that was actually given before the Health Committee in 533, actually talking about baseball arbitration or something similar to that is a mechanism that DMHC already used. In fact, I think Capel was the one who gave that testimony. And so, so I'm sort of surprised to hear that that's a problem again, since I was first told it was a problem, then I was told it wasn't a problem, and that's sort of what we kind of use anyway, and then now it's a problem again. Now, maybe we'll just leave it there and say that we won't try to, but I think that I do think, as Senator Roth brought up, perhaps we could have some further conversations looking at about losers pays. You do have in the IDRP process, the challenge is that as providers, providers are usually not big organizations, they're smaller individuals. Plans tend to be much larger, and so they're better able to bear administrative judicial burdens than individual practitioners or small groups. And so I want to be sure that that in the IDRP process, I mean, fine, you win most of the time, but if you're always paying the fees, you're still coming out with a loss unless the fee somehow is going to be, when you win, you get reimbursed. Otherwise, that fee's cut out of whatever you get. So you still end up losing anyway. And so hopefully we can continue to examine that particular issue.
Thank you, Dr. Pan, again, for your thoughtful comments and your question. Two responses. One is we do allow for bundling of claims in the IDRP process, so it's not a one-off every time. You can be a little bit more efficient and aggregate or bundle some claims together. And then second, on the issue of IDRP, baseball arbitration, and loser pays, based on our outreach, that's a major challenge for the administration.
Okay.
And when it becomes a major challenge for the administration, it becomes a major challenge for us, because we need to get a bill signed in order to protect consumers, which is all of our goal. So we will continue to be open-minded, but that has not changed for some time now, and I don't have a lot of confidence that it will. So I just kind of wanted you to understand the thinking behind it.
Okay. So I guess what I would just say is I appreciate your consideration. I think if there's a commitment from you to work on, particularly I think the issues around copay and network adequacy, I would be happy to work with you on that if there's a commitment from you to work on those issues.
So I'd like to make some comments just with regard to that. First of all, let me just say that I believe that the consumer should not be involved, especially in the fact that they may not know that there's a provider that they don't know about. I understand that there's various iterations, and I keep hearing the term, this is a work in progress. Well, after this, there's appropriations. We don't have a lot of work in progress time left. Is this the perfect bill? Maybe, maybe not. But this is the bill in chief, which I am prepared to support right now. With regard to baseball arbitration, it's been battered around, and I commend the authors because it could be a poison pill to the administration, and I understand why they have to do it and what they're doing politically to get a signature, but more importantly, to keep the consumer out of the middle. With regard to the copay, I cannot be supportive of that, and I've had a conversation with the authors, and they know why. So yes, there's some providers that take some plans, some that don't, but at the end of the day, providers still ultimately collect the copay. And to allow that provider that does not have a contract and that provider that balance bills, that they're going to get paid a set rate and then have somebody else collect it for them while everyone else is doing the right thing, I think is inappropriate. So I'm not prepared to have that conversation, and I would oppose that along the process because we've had that conversation. Other than that, let me finish. Other than that, I am prepared and to support this bill as it is. And I'm going to encourage all of my members to get it so we can pass it out and move it along, get it to the governor's desk. Yes, Senator Pan.
So I appreciate what you said. Actually, what I've suggested, for that, in fact, I explicitly did not mention working on baseball arbitration, although I did bring it up in the questioning because I appreciate your answer and accepted your answer. I also, when it came to the copay, I had proposed not saying that perhaps the plan collected, but then we should have a mechanism. We should think about whether we can work out a mechanism where the physician who has to collect the copay can, that there's a way to do it in advance instead of doing it post hoc. Now, obviously, there's a little bit of work that might have to be done between now and appropriations, but again, you know, the challenge is trying to collect a copay afterwards when you don't even know what the amount is and so forth, that there should be some kind of notification for the physician who has to do it so they know what they have to do, and also ideally before the service if possible. That does, of course, require certain demands on the plan being, you know, the plan, the provider communicating as to what the provisions of the coverage that the patient has. So if the provider is going to be collecting the copay, they need to be given the mechanisms to be able to do so reasonably instead of trying to pursue that at the back end when, of course, it's much more difficult to do so. So, and I wouldn't say I wouldn't say let's hold up the whole thing if we can't quite come up with the answer, but I'm hoping that we can work on looking at some of those mechanisms and as a way to try to address. And I hope, Chair, that would be something that would be acceptable to you as well, because I think we're trying to figure out how to be sure we land some fairness in this. And so if the provider is going to collect the copay, then let's have the provider be able to collect the copay. So
Through the chair?
Yeah.
I appreciate that. There is currently nothing that prevents a provider from collecting a copay in advance.
Right.
I did that all the time in my dental practice. We have a plan, we have a contract, we know what the plan is going to pay us within reasonable parameters. We know that. There's nothing to prevent a physician, a dentist, an optometrist, anybody from collecting a copay in advance. So I'm not sure that creating a special mechanism for that, because that ability already exists.
Well, the mechanism is that you have to know, because you can collect the copay when you know you have to collect the copay and how much it should be. I just, it's about getting the information to the non-contracted physician who doesn't have a contract far enough in advance so that they would have the capability to do it. That's what I meant by mechanism. It wasn't anything more than that, because if you don't have a contract and you don't know what the plan copay is supposed to be, how are you supposed to collect it? Are you going to say, well, you know what, I'm not sure what you're not a contract, just give me $100 and I guess I'll refund you whatever's, if it turns out your copay is, I mean, it's, you'd have to, so I just want to be sure that that the information for the provider is provided as to what the copay is. Again, trying to keep the patient out of the middle so that they can communicate with the patient and take care of that, and the appropriate expectations are set in a timely manner so that you don't have a provider, I mean, you're still going to, otherwise the patient's still going to get a bill. It's not a bill for this much, but it's going to be a bill for the copay. However many weeks afterwards, when the provider finally says, you know what, the plan sent me an information, said, here's your payment for the check, and guess what, the remaining $200 you got to collect from the patient, right? And you don't find that out until weeks afterwards. And now you're trying to chase down the patient for that amount of money, right? Because, and you're sending checks, notices, and collections agencies and so forth. I mean, yes, hopefully we're not sending them, they're not, but it's not as big of a bill, it's still a bill. So I'm hoping that there's some kind of way to think about how we can get that information up front, some requirements to get the patient up front for the physician in the timely manner of provider so that they can know what the copay is and that there's an expectation and that they can reasonably communicate with the patient about that and to collect it in a way that isn't about chasing down the patient weeks afterwards and said, oh, you have a copay and I'm trying to get, who's this? So anyway, and they're still going to say, who's that doctor? Because they don't always know who the pathologist or the radiologist is. So that's the part I hope that we can try to address.
Appreciate it.
Yeah.
I mean, just with the mocked up amendments that are provided by the authors, I'll read what one of the amendments is. At the time of payment by the plan to the non-contracting individual health professional, the plan shall inform the non-contracting individual health professional of the in-network cost sharing owed by the enrollee. I think that addresses, I don't know how much clearer you could address that, but I'm happy and convinced and willing to accept this, and I'm going to support the bill.
So actually one more.
Yeah, go ahead.
So again, I just, if we're willing to work on those two issues with those parameters, I'd be happy to work with you on that.
I guess I'll say this. We're always willing to listen. And of course, we're willing to listen to you. We want to listen to you. If you have input to make it a stronger bill, we'll listen. But on the copay issue, we had a proposal where the plan collected the copay, and we're not going to go back there. And I know you're not asking to.
I'm not asking you for that. I'm just looking at, in fact, I appreciate that provisions in there. Just it's a timeliness, being sure you get the information in a timely manner so that they can, again, it's about relating to the patient. So actually, that's not the big, I think the other issue is really perhaps the more important one, which is the network adequacy piece. And
that was the point I wanted to make. I think we are more likely to have success working on network adequacy together.
Okay.
And willing to work with that on you. But certainly, if any thoughts you have, Dr. Pan,
okay.
We consider the month-long July recess a work session for us to continue to make this as strong as possible.
Well, actually, with that commitment, I'd be willing to give a courtesy vote for the bill today. Thank you.
Thank you, Dr. Pan.
Seeing no other questions or comments, do we have a motion? So moved. Moved by Senator Roth. This is item number 1, AB 72, healthcare coverage. Oh, would you like to close?
No, respectfully ask for your aye vote.
What, you want to spend more time up here talking?
I am good. You've been very generous. Thank you,
All right.
Mr. Chair.
Healthcare coverage, Chair is recommending an aye. Do pass as amended. 2 appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Monning. Nielsen. Nielsen, aye. Pan. Pan, aye. Roth. Roth, aye. Wolk. Where is that?
Currently has 4. Obviously, we need more members. We'll place that bill and call. Mayor Bonta, I believe you have another bill, number 7. Is that correct?
Yes, Mr. Chair.
AB 1726, data collection.